Hi everyone, my name is Abigail Ferdinand, and I am the current PGY2 Oncology Pharmacy resident with Monument Health in the Cancer Care Institute. And today I'm going to be talking about the management of tumor lysis syndrome and hypercalcemia of malignancy. For the first topic that we'll be discussing today, tumor lysis syndrome, I also wanted to make mention that this presentation is specifically tailored towards inpatient oncology management, more so focused on our oncologic emergencies. Some of these principles can certainly be used down in the Cancer Care Institute. However, moving forward through the rest of this presentation, a lot of this will be tailored towards our inpatient management. Talking a bit about how frequent tumor lysis syndrome is, it is actually one of the most frequently encountered metabolic complications specifically related to hematologic malignancies, and unfortunately it can have a really high mortality rate, anywhere from 29 all the way up to 79%. Thankfully, with early and aggressive intervention, this mortality rate can be decreased significantly. I really like this diagram that's detailing the pathophysiology of tumor lysis syndrome and specifically looks at all of the different complications that can occur when you have a tumor cell that lyses. Tumor lysis syndrome can occur when cancer cells release their contents into the bloodstream. Now, this can occur either spontaneously or following chemotherapy administration. If it does follow chemotherapy administration, we can expect to typically see tumor lysis syndrome within 12 to 72 hours after that infusion. What happens in tumor lysis syndrome is there is an influx of electrolytes and nucleic acids that are released into the circulation. When this happens suddenly, we end up having hyperkalemia, hyperuricemia, and hyperphosphatemia. Because of the hyperphosphatemia, we actually have calcium and phosphorus precipitation, and this will lead to hypocalcemia. This can have life-threatening effects, specifically on the myocardium, the kidneys, and the central nervous system. Clinical tumor lysis syndrome is going to be diagnosed when there's one or more of these three conditions that arise. One of these is acute renal failure, and this is defined as a rise in the creatinine of 1.5 times or more the upper limit of normal, and this is not attributable to medications. Arrhythmias, this can also include sudden cardiac death, and finally seizures. As I previously mentioned, tumor lysis syndrome is going to be more common in hematologic malignancies, especially those that are rather bulky, such as ALL, AML, and Burkitt lymphoma. However, I did want to mention that tumor lysis syndrome has been documented in solid malignancies and solid tumors as well, specifically small cell lung cancer, germ cell tumors, inflammatory breast cancer, and melanoma. There's also a laboratory definition for tumor lysis syndrome, and this is using a system known as the Cairo-Bishop classification, and this is defined as 2 or more laboratory changes that must be observed within 3 days before or 7 days after cytotoxic chemotherapy. And those laboratory definitions are seen on this chart here. And then as well as the other definitions that we previously mentioned with the creatinine cutoff, the cardiac arrhythmias, and seizures. There are certainly risk factors for patients when we look at who is more likely to acquire tumor lysis syndrome. As I mentioned, anytime the malignancy is rather bulky, and especially if it's sensitive to chemotherapy, this certainly can increase the risk. This occurs in lymphoproliferative malignancies, as well as if there's an elevated LDH, an elevated white blood cell count, anytime there's extensive bone marrow involvement or extramedullary involvement. Other risk factors to consider include dehydration or renal dysfunction at baseline, and then it's important too to see what their baseline uric acid level is. If this is elevated at baseline, this also increases the risk for acquiring clinical tumor lysis syndrome. Obviously, with the complications that can occur from tumor lysis syndrome and the relatively high mortality rate, The goal is to try and do everything we can to prevent this from occurring. It's important that we begin preventative measures and medications 24 to 48 hours before chemotherapy is initiated. Now, for both prevention and treatment, hydration with crystalloids is going to be our standard of care. It's also important, too, to take a look at the patient's medication list and try to eliminate any medications that could possibly contribute to electrolyte abnormalities. It is recommended to hold thiazides and/or potassium-sparing diuretics, discontinue any supplementation with calcium, potassium, and phosphorus, as well as holding ACE inhibitors and any concurrent nephrotoxic agents, and finally discontinuing enteral or parenteral nutrition. Ultimately, with the prevention of tumor lysis syndrome, patients are going to be managed based on their level of risk. For patients who are low risk, it's recommended to do prevention strategies that include hydration alone with close monitoring. If patients are intermediate risk, this is going to introduce more therapies with fluids, allopurinol, and as-needed loop diuretic, and this is going to allow for aggressive hydration to occur. If patients are high risk, the management is going to look very similar to intermediate risk. However, rasburicase can also be used. The first medication that I wanted to talk about is a very important medication for not only the prevention but treatment of tumor lysis syndrome, and this is allopurinol. As a reminder, allopurinol is a xanthine oxidase inhibitor. The recommended dosing for allopurinol in the oral dosage form is 300 milligrams per meter squared per day, or 10 milligrams per kilogram per day, given in 3 divided doses every 8 hours, with a maximum recommended dose of 800 milligrams per day. In the IV formulation, the dosing is a bit different, with 200 to 400 milligrams per meter squared per day, and this can be given as a single daily dose or divided in 2 to 3 doses. The maximum recommended dose is lower than the oral formulation at 600 milligrams per day. It's recommended to begin therapy with allopurinol 1 to 2 days before the start of induction chemotherapy, and this may be continued for 3 to 7 days thereafter. One of the really important things to remember about allopurinol is that it does not alter uric acid that has already been formed. Another important thing is to remember the time to plasma uric acid control with this agent. This is roughly a day, or about 27 hours for this to occur. Allopurinol also does have renal dose adjustments. And finally, it's not recommended to use allopurinol if the pretreatment uric acid level is elevated at 7.5 or greater. If this is the case, then rasburicase would be the medication that we would want to use in this situation. The next agent that I wanted to discuss is rasburicase. Now, unlike allopurinol, the time to uric acid level reduction is going to be much faster with rasburicase, approximately 4 hours. This is a recombinant urate oxidase that converts uric acid into a water-soluble form known as allantoin. Unlike allopurinol, it does not cause accumulation of xanthine and hypoxanthine. This one also has some interesting caveats, as it is contraindicated for use in pregnancy and in patients with G6PD deficiency. There are a few different dosing strategies that are recommended for rasburicase. One of them is a weight-based dosing strategy that has 0.05 to 0.2 milligrams per kilogram once daily for 1 to 7 days. This typically averages anywhere from 2 to 3 days. For prevention, it's recommended to do a single dose of 3 milligrams. And finally, the fixed dosing regimen is going to be something that the pharmacy team recommends for patients who do need rasburicase, anywhere from 3 to 6 milligrams. One thing that's important to note is that this medication is rather expensive. A 1.5 milligram per each solution is approximately $1,000. and the 7.5 milligram strength is approximately $5,300. Therefore, it's been found that the fixed dosing regimen is not only cost savings, but it leads to the same clinical outcomes as well as safety and efficacy for the patient. And finally, I wanted to include this diagram of purine catabolism to demonstrate where allopurinol and rasburicase are working and exerting their effect. With all of the different metabolic abnormalities that can occur in tumor lysis syndrome, obviously the management of these patients can become rather complex. I'm not going to read through this full chart for you, but I think it really brings together some of the different things that need to be thought of when dealing with a patient who has tumor lysis syndrome and all of the various interventions that we can anticipate we may need for appropriate management. Now to transition to our second topic of this presentation, I will be discussing the management of hypercalcemia associated with malignancy. Hypercalcemia is an oncologic emergency that is relatively common. Up to a third of cancer patients at some point in their disease course will experience hypercalcemia, and this can occur in a wide variety of tumor types: breast, lung, renal cell carcinomas, multiple myeloma, as well as adult T-cell leukemias and lymphomas. There are various mechanisms for how hypercalcemia can manifest. Some of these include systemic release of parathyroid hormone-related peptide, specifically by the tumor. Also, local paracrine stimulation of osteoclasts by metastases to bone. And finally, systemic secretion of vitamin D analogs by the tumor itself. To further expand on the pathophysiology of hypercalcemia of malignancy, approximately 80% of hypercalcemia is caused by parathyroid hormone-related peptide that is released by the tumor. This is really going to mimic the action of PTH on bones as well as the kidneys, and this does not influence intestinal absorption of calcium. Bone metastases may also cause a local paracrine effect, and this produces several factors that ultimately stimulate osteoclasts. When this occurs, we have bone resorption with resultant hypercalcemia. And then finally, and this one is rather rare, but the tumor itself can actually produce PTH. The presentation of hypercalcemia can sometimes be nonspecific. We do have this standard saying that we think of bones, stones, moans, and groans. As related to hypercalcemia, this is talking about the skeletal pain, nephrolithiasis, abdominal discomfort, and altered mental status. Ultimately, we can see changes on the EKG as well, and this can lead to arrhythmias. There really is no absolute level of calcium at which patients will become symptomatic. Likely the rate of the increase is going to be more significant than the actual magnitude of the elevation. Relatively high levels may generally be well tolerated if that rate of increase was more gradual. Immediate treatment of a calcium level below 12 can often be deferred. Patients who have moderate hypercalcemia with levels of 12 to 14 should be treated based on clinical judgment as well as if they're symptomatic. Any patient, however, with a serum value of greater than 14 is generally going to be symptomatic, and they should receive prompt intervention. And finally, of note, cardiac arrest can occur when those levels are 15 or greater. It's also important to remember that if we're measuring the total calcium, we need to correct for hypoalbuminemia with the equation listed there. This is going to be the corrected total calcium that's equal to our total calcium plus 0.8 multiplied by 4 minus the measured albumin level. Similar to tumor lysis syndrome, hypercalcemia also has a relatively high mortality rate, right at 50%. Therefore, urgent intervention is also going to be needed for this oncologic emergency as well. For starters, hydration is going to be important, as almost all of these patients will have intravascular depletion. This can be achieved with normal saline, an initial bolus of 1 to 2 liters, followed by an infusion of 200 to 300 mL per hour to achieve a urine output of 100 to 150 mL per hour. Once the patient is euvolemic, IV Lasix can be utilized, and this is initiated to promote calciuresis. Of note, thiazide diuretics should be avoided as they increase calcium reclamation from the urine. Other agents that we have include bisphosphonates and steroid therapy. Steroids are going to be most effective in patients with Hodgkin's or non-Hodgkin's lymphoma or any malignancy that overproduces calcitriol. The glucocorticoids inhibit the conversion of 25-hydroxyvitamin D to calcitriol, therefore decreasing the gut absorption and the renal reabsorption of calcium. One really great class of medications that we have to treat hypercalcemia includes the bisphosphonates. These work by reducing the osteoclastic bone resorption. Some of the agents include pamidronate or zoledronic acid. Zoledronic acid is going to be one of the standard medications that we utilize at Monument Health, and this is dosed at 4 milligrams IV over 25 minutes. Of note, when you're using it for the indication of hypercalcemia associated with malignancy, there are no renal dose adjustments based off of the creatinine clearance. However, it has been noted that when the serum creatinine is greater than 3, there is an increased risk of tubular necrosis. The onset of action for these agents is approximately 2 to 4 days, and naters in approximately 1 week. Therefore, retreatment may be considered after 7 days if the calcium level is still elevated. Some common adverse effects associated with bisphosphonates include bone pain, ocular inflammation, electrolyte abnormalities, and osteonecrosis of the jaw. Another class of medications that we have to treat hypercalcemia include the rank ligand inhibitors. It's important to note that we should use these if hypercalcemia is refractory to bisphosphonate therapy. We can utilize denosumab 120 milligrams sub-Q weekly times 3 doses during the first month and then every 4 weeks thereafter. The onset is going to be similar to that of the bisphosphonates at approximately 2 to 4 days. Again, glucocorticoid therapy is really going to serve as an adjunctive role, specifically in lymphoma patients. If it is deemed appropriate for use, some of the different agents we have include prednisone or hydrocortisone. Prednisone can be dosed anywhere from 20 to 60 milligrams per day for a total of 10 days, or IV hydrocortisone can be used, 200 milligrams daily for 3 days. You can anticipate to see a reduction in the calcium level within approximately 2 to 5 days. Calcitonin is also another agent that we can use as adjunct. This can be dosed anywhere from 4 to 8 international units per kilogram, either sub-Q or IM, but not intranasally. And this can be dosed every 12 hours. We can use this as an alternative to aggressive hydration, especially in patients who are not appropriate for fluid or excess amounts of fluid, such as those with CHF. You can anticipate that this will reduce the calcium 1 to 2 milligrams per deciliter within about 4 to 6 hours, with a maximum response within 12 to 24 hours. It's really important to note too that this is really only effective for the first 48 hours, and it can cause a tachyphylaxis. And then finally, for completeness sake, I did want to include some of the other treatments for hypercalcemia. These include mithromycin and gallium, as well as dialysis. However, I did want to mention that the mithromycin and gallium is really of historical interest only, and these are no longer utilized as treatments. Here are my references. Thank you very much for listening to this presentation. If you have any questions or wish to further discuss, I can be reached at aferdinand@monument.health.